This is the video that didn't play the other day that generates these types of scaffolds. This is the electrospinning video. So what I want to do is just play this video for you. I'm going to kill these lights. So that's the kind of the spraying of the proteinaceous fibers that I was trying to describe. And I think just being able to see it in motion sometimes is helpful. At least it's helpful for me. Let's play it again. But you can alter that flow rate. You can alter the concentration of the protein. You can alter the voltage. And essentially what you get is these different unique materials. The whole concept here is kind of trying to create clever ways to make replacement extracellular matrix. And we were talking on Tuesday a lot about the ECM and how important I feel the ECM is. The other thing I really important is, I think is important is our dolphins. So what did the dolphins shout when they got stuck in the seaweed? Kelp. Okay. I see, better than Tuesday already. Not difficult to do, right? What does one house say to the other? How's it going? What kind of dog do you find in a bakery? No, but I mean, it's a good guess. A Doberman. A Doberman. I like that. That's pretty good. Clever. I mean, it's probably funnier than mine. Purebred. But Doberman hot dog is pretty good. It's pretty good. You guys are catching on. Okay. I'm going to come back to this. Joseph, you're supposed to remind me, so thank you. I know you forgot, but that's okay. I didn't. All right, so significance about today, 11:59 p.m. Post-quiz due. Just a little cadence. Next week, we're going to get into adaptive immunity or specific immunity. And then on September 30th, we have exam 1, our first exam. And I'll talk a little bit more about that, but that's going to be an online exam. I think I mentioned that the first time we were together, but I thought I would kind of prepare you for that. Now, I also don't want you thinking, oh, sweet, that's going to be easy. It's not. It won't be bad if you're studying. And if you're kind of treating this class like a regular class, I think the online format you'll really like, because you don't have to show up here. You can. You'll have this space if you want it. And most of the time, the internet's pretty reliable here. But you can do it from home. It'll open at 7 in the morning. It'll close at 11:59 p.m. on test day. You'll have an hour to take the exam, open book, open notes. I want you to work alone. No way for me to police that. Again, like we talked about the first day, like it's just sort of trust and character, right? And it's material that you really need to know. So you're kind of only cheating yourself if you're not doing this for learning, I guess is my point. So I'm not going to try to mandate or police good behavior, at this point. There's certain things I have to do. So if I see things that, the university is passionate about, then I have to report it. But that's how the exam will go, okay? Get your grades pretty fast. We can talk about your exam in office hours, or you can schedule a meeting. Again, I want to reiterate, I have standing office hours. I know that may not work for you. I totally understand that. I just have to pick something that works for my schedule. So I can make other times available. We could do it by Zoom. We could do it in person. Usually I'm only here Monday, Tuesdays, and Thursdays, part of the day. So Zoom is a little bit easier for me, but it's also easier if you need to talk privately about your grade or something that's going on, a one-on-one is a better approach than office hours. Because there's a whole nother class that pops into office hours on Monday that's like 3 times the size of this one, but it's online. So just throwing it out there. I know that not a lot of office hours happen before the first exam, and then all of a sudden the first exam happens and everyone wants to come talk. I don't know. I'm really dense. I can't figure out the correlation, but so that's probably what's going to be happening. Okay. All right. Let's pick up where we left off. And I think we're going to have some fun today, talking a little bit about science and technology and clinical application. But before we get into that, let's talk a little bit more about these different phases that we introduced when we first broached this topic on Tuesday. So the coagulation or the inflammatory phase is this trigger. It's really important. It's part of the normal wound healing response. In fact, you can't have it if it doesn't happen. So I'll bring this up again later, but a case in point, we studied this pharmaceutical pathway or this pharmacokinetic pathway that pharmaceuticals get impact, which was the steroidal pathway with eicosanoids. You remember that? And we were kind of playing drug development, and we were trying to decide, do we want to have something that lightly modulates inflammation? Maybe we prescribe an aspirin. If we want something that kind of knocks out an entire pathway, almost obliterates inflammation, what would we prescribe? A steroid, a corticosteroid. So in orthopedic medicine, it's very popular to do corticosteroid injections. And some of you are shaking your head. Either you've had this done, you know somebody, mom or dad, grandma or grandpa has a sore hip, kind of a sore shoulder, knees are very common. Synovial joints are very common as we age, where there's a lot of pain and discomfort, and there's osteoarthritis that's happening there, which is an inflammatory disease. So it's very common for practitioners to say, oh, inflammation, I have the solution. Let's use a corticosteroid and eliminate inflammation. Well, 2-3 days later after the injection, patient feels phenomenal. No more inflammation. That high, I use in air quotes, but that euphoria of no pain lasts for about a week or two. And then the corticosteroid wears off. And what happens? The inflammation comes back, right back to where you started. Now, you can't actually have a corticosteroid injection too early, so you have to wait like another 6 months. And now you understand, because if you do it too often, you knock out inflammation, and that corticosteroid can have systemic effects, and now the patient's at risk for other problems. You understand kind of that dilemma that we've got, and probably why people are getting corticosteroid injections. They do work. I'm not saying they don't work. I'm just saying they work, and there's some things to consider. It's to eliminate inflammation, and which when you subside inflammation, you put less pressure on the joint space, so the nociceptors aren't stimulated, and so pain goes away. So essentially, yes. Okay. So that's just an example of how inflammation is actually really important. And the trigger here is breaching of the skin. We're going to talk a lot about skin wound healing today, but we'll get into some orthopedics, and we'll get into some chondrocyte, some joint space type of discussion. So this is another schematic diagram where you can kind of appreciate the epidermal space, the dermis that's deep to it, the lesion. I've kind of tried to draw an example lesion here on the board that I'm going to come back to. You can see the vascular response, platelets, a clot. You've dropped the level of oxygen in the wound because you're compromised blood flow. Bacteria can come in. So this is the coagulation inflammation phase. And it's quickly followed by this migration or this proliferation phase, where you've got new blood vessels via what term? Angiogenesis, nicely done. The development of new vessels from pre-existing vessels. These branch out, move into the wound space, And that brings with it blood flow to address this dropping oxygen here. And it also brings with it circulating monocytes that can actually extravasate out into the tissue and become these tissue macrophages. And we're just talking about all the steps that we've already looked at. So in the migration proliferation phase, you would expect to see an increase in blood flow. You're going to start seeing fibroblasts migrate into the wound bed. You're going to see macrophages presence. And as you continue, you get into the remodeling phase. So you angioregress, you drop out these blood vessels you don't need anymore. You completely epithelialize the wound bed, so this completely covers. And now you lay down this fibrin, this fibrosis or this collagen, this collagen that the fibroblasts help to contract the fibers of the collagen and pull the tissue together. Remember this? So a question was asked at the end of class, and I meant to talk about it on Tuesday. So it was sort of my reminder. Sometimes this doesn't come out very good. And so you can come in for scar revisions. And so really what we do in a scar revision, and usually it's the plastic surgeon that does this, is they try to take a wound that healed by second intention, which is what we have here, because it's kind of a big gap. And we try to convert it to a wound that will heal by first intention. And so have my handy dandy wound here. You've got a fibrous collagen scar. And what we're going to do as the plastic surgeon is we're going to come in here with a scalpel and we're going to surgically resect and we're going to convert this to look more like this. That makes sense? So we remove this, we bring that together, approximate it, and now you have nice two clean surgical incisions that will heal by second intention. And that's a scar revision. Pretty straightforward. Now, depending upon where it is, it's more difficult to do than just drawing it on the whiteboard, right? That's where the practice of medicine comes in. But that's the philosophy behind it and what's going on scientifically. Okay, so now we're going to get into some more gory type of images. Y'all ready for this? So in a full praise the heavens, right? We got some religious activity happening up front. Full thickness dermal wound. Sorry, is that too much? I tried to warn you guys. There's another one coming that maybe not yet. So do you see how we're going to try to approximate that? We're going to try to do exactly this. So you're trying to approximate the wound borders with suture, surgical glue, staples as quickly as possible. Not tomorrow, not 2 days from now, not next week, because that inflammation phase is happening instantaneously. And then you move into the granulation tissue formation and you move into proliferation and migration. So you want to capture this before stuff's actually happening. Otherwise, you're going to have to do some kind of revision. So sometimes the borders are not an option. There's no borders. This is a burn patient. So in burn patients, it's not uncommon that the skin is so charred and there's no wound margin for you to actually approximate. So what you have to do is you have to cover. So you use all sorts of different types of technologies to do coverings. And the coverings are considered full thickness dermal wound coverings because you can't bring it together like what we did here. So we'll take skin from the patient from somewhere else and we'll graft it. A very common area to get it is from the thigh, the buttocks, the lower back, assuming that that's not where the burn is. We can use cadaveric allografts and xenografts. So allografts, so autologous is self from the self. Allo is from somebody else, but same species. Xeno is a graft from another organism, typically a cow or a pig. So bovine for cow, porcine for pig. Challenge with xenografts in certain cultures for cultural or religious reasons, you're not allowed to use those. Okay. Also, allografts for cultural reasons in certain cultures. You cannot use tissue from somebody else. You can't use cadaveric tissue. You're not allowed to bring cadaveric tissue. Some cultures, you're not even allowed to be in the same room as a cadaver, let alone have that material implanted on you. Okay, so this creates some clinical challenges that hopefully you're understanding. We have to be sensitive here. So now we introduce this whole world of commercial dermal substitutes. What are some substitutes? Because these actually work pretty well, but there's not always tissue available. And for the patient, like in this previous slide, there's not much down here. And if it's at 80% of their body, they're not going to be pulling skin from anywhere else, because now you create a wound to treat a different wound. And if they have this much wound, they're not going to be like, I don't want to compromise his back. He's going to be uncomfortable enough as it is. So now we introduce this world of dermal substitutes. So this was a project that was back in the 90s. So this was the first company I went to work for back in the last millennium. That's how old I am. So the dinosaurs were not here, but I was closer to them than you. And we had, that's a true statement. We have sort of three different pathways, three different projects that we worked on. But I actually, for this talk, I'm going to focus on Dermagraft. So Dermagraft was a dermal substitute. And the way that we made it, we manufactured it, is we created a scaffold. So you've seen, we weren't electrospinning. This is way before electrospinning was in the field. We were using a mesh, though. It was a bioabsorbable mesh. So it would be implanted in the body and it would dissolve over time. It would resorb. You guys have had surgery and had like resorbable sutures. A lot of times oral surgery, like so when I have to come back for my sutures to get taken, oh, they'll just dissolve. You're like, so I'm going to swallow them? That's kind of weird, right? They break down in the presence of water through hydrolysis. We took a scaffold. We would seed the scaffold with cells, human dermal fibroblasts. I'll tell you in a second where we got them from. They would grow within the scaffold and start making matrix proteins that are extracellular matrix proteins like we just got done studying. And then they would make these soluble factors known as growth factors that are signaling molecules. And the signaling molecules, like we looked at in some of the slides, they tell the surrounding tissue how to repair. They're the messengers. So we call these insoluble as well as soluble factors. And after a few weeks in a bioreactor, which is just a fancy word for an incubator that runs at about body temperature, humidity, and controls all the fluids and homeostatic conditions that are appropriate, like pH and oxygen and glucose, and get rid of metabolic waste products, we actually would make a human tissue. So here's a picture of our dermagraft. You can see the scaffold. This is a scanning electron micrograph. This is a fibroblast, and do you see how it's grabbing onto the scaffold? So it's interacting with its extracellular matrix environment. This is my kid in a jungle gym picture. And that's how cells behave. So we just tried to mimic that condition outside of the body and create a fully formed, what we call tissue engineered skin. So where do y'all think we got the fibroblasts from? So I talked about stem cells. They're not stem cells. Okay, so they're not embryonic sourced. And they're not stem cells. But they're really, really close. And they're very, very young skin cells. Any guesses? Bryce, you're not allowed to answer because you know. I'll give you a hint. You want me to give you some hints? We'll play 20 questions. So you still have 20 guesses, but I'm pretty soft, so I'll just kind of give you answers and then you'll get it right away. We got them only from little boys. That's a weird answer, Keller. It's the truth. Discarded boy tissue. What's that? Discarded foreskin from circumcision procedures. Okay. Tissue's thrown away. It gets donated to the company. We harvest the fibroblasts out under informed consent from the parents, of course. But I mean, this is tissue that's going to be thrown in the trash anyways, right? I know scientists are kind of weird, but we like to recycle. We repurpose everything, man. Okay, we're very green. So not stem cells, but you probably will never forget that. There may be a test question. So these are human dermal fibroblasts from foreskin circumcisions. That tissue grows like crazy, by the way. Like from one harvest, you could actually culture cells to fill about 200 football fields of human skin. It's a lot of foreskin, I'm just saying. It's a lot. Okay, yeah. I mean, that one's funny and it's not even on a cue card, right? It's a great question. What about the skin color? So at the cellular level, all of our cells look the same. And skin tone has nothing to do with the cells. It's actually a product that a cell makes that's a protein known as what? Melanin. And it's made by what cell? Melanocytes. That's the only difference. So fibroblasts between all of us, there's a lot of diversity in this room, different skin tones. Our fibroblasts are the same darn color. Yep. Doesn't matter. Yep.
So how would you match, I mean, I guess it's not the most important thing in the world, but
so color-wise, the skin graft looks, so when you're doing cadaveric skin, that's an issue. So in cadaveric skin, if you have a more dark complected recipient and a fair complected donor, you're going to see a color variation. There's no question about that. But like that previous picture that I showed, you're going to have a better aesthetic outcome no matter what, I promise. And that's sort of the least of your concerns. Yeah. But that's not here, but in that cadaveric skin or allograft, you do have that issue.
I was wondering if native melanocytes would be able to invade this.
Yeah, so there's a lot of space in here. The question is, what about native melanocytes? There's a lot of space in here for other cells to infiltrate. So the nice thing about this graft is, I'm going to show you, the story's not over. Like, you guys are all excited. We're not even there yet. Okay, so hold tight. But there's a lot of space for native tissue to come in, native cells to come in, like melanocytes, and make their own melanin. And then you basically see no color differences, which is kind of nice. This is a diabetic foot ulcer. It's a little gory, bottom of a foot. So this was first developed as a treatment for what we call DFUs. Remember the DFUs? I'm not calling anybody anything. It's just a name in the clinical literature of diabetic foot ulcer. And so on week 0 in the upper left, and these were this is back at Advanced Tissue Sciences in the 90s. This was a clinical trial at UCLA. And in order to be eligible for the trial, the patients had to have a non-healing wound for 6 months. So that wound that's the heel, the bottom of their heel, it looked like that for 6 months. Yeah, that's not fun. Here's the saving grace. They really can't feel it. The reason they got it is because they couldn't really feel that they had a cut. Because a lot of diabetics, they have neuropathy, which leads to parathesis in the lower extremities, which is like that, when your foot falls asleep, that pinprick feeling. So they have that all the time, which is super annoying. But then they step on a carpet tack or they kick the bedpost or whatever, they get a little incision on the bottom of their foot. And because they don't have great blood flow to the distal extremities, that's why the nerves start dying. That's why they get that parathesis. That's why that won't heal, because you can't get blood flow. So the problem with diabetic foot ulcers is if they progress, they become infected. They become gangrenous, a gangrenous necrosis. We've looked at that. And then unfortunately that starts moving up proximally. So now it affects the whole foot, maybe the toes, the lower leg. And then what do we do clinically, unfortunately? We have to amputate. Okay, certain populations are at high risk for this. And so this is a big need for us to be treating diabetic foot ulcers. This happens to be kind of one of the sweet spots of where I really try to do a lot of research. And it started a long time ago. I mean, this is like 30 years ago, right? The 90s. So we treated this non-healing wound. Each week, a fresh piece of dermagraft, and you see by 10 weeks, it was fully closed. Pretty phenomenal work. This wasn't just my work. This was the company's work. I had a component of the project, lots of people involved. Company was like 205 employees. Okay, startup company, a lot of fun. This is a laser Doppler study. So you're looking at like week in a different patient, but like week 1, 3, and 5. So it's not the whole thing, but you can see the circumscribed area in the black and white on the left, and then the laser Doppler. The cooler colors like blue and black are low blood flow, and the brighter warm colors like the yellow and the reds are higher blood flow. So you can see after 3 weeks, we've moved the blood flow outside. It's higher inside of the wound now than it was at the first week. So that's really the secret, is this was a very angiogenic material. Looking at the production of vascular endothelial growth factor, VEGF, over a 2-day period, and as it continued, the graph continued to go up. This is a control piece of dermagraft. This is a control piece of mesh, no fibroblast. This is an actual piece of dermagraft, and hopefully you can appreciate the differences. A vast amount of new vasculature via angiogenesis in the dermagraft treated tissue versus the tissue that was absence of the fibroblast. So the cells were making the VEGF. The cells were making the soluble factors. They were making the extracellular matrix proteins. They were stimulating this healing response. Okay, this one's pretty hard to see. It's a person's face. So if you need to look away, now's a good time, okay? This was an individual that presented at UCLA Trauma Center with a chainsaw accident to the face. And you can see pretty aggressive lacerations. Young individual, not a diabetic foot ulcer, off. I mean, that's really, Keller? I mean, you all took anatomy, so you know you're tracking with me. You see why we want the prereqs? This is not a diabetic foot ulcer. And thanks to 201, you're all tracking with me. This would be considered off-label use, which is very common, which means according to the FDA, you're not allowed to treat. But a lot of physicians and a lot of companies will say, well, the physician says it's okay. Company says we have nothing to do with it. We tell you it's off-label. You decide as a practitioner how you're going to treat your patients to help them. Well, I don't care. It's not a foot. I'm going to try to help this guy. Okay, that's what most practitioners will say. So that's a huge tug of war that happens in the industry between the FDA, physicians, and medical device or medical technology companies. So this patient was treated with dermagraft. Immediately, it was packed in the wound. The wounds were approximated as best as possible. And this is 1 year later. Okay, so now what I want to ask y'all is group up, little discussion. Do we have complete regeneration, resolution? Or is it repair, healing? Which one is it? That's what I want you to talk with your neighbor about. And why? Tell me why.
Anything else outside of that, I'm totally fine. You're so brave. Like that would be the last version of it. For some reason, even the coloring on the lights, like I hate it. But I can look at like a gas basically like okay. See, my thing is like products made, I'm like,
Okay. I love the dialogue. No, I was eavesdropping in some of the groups. So let's hear from you.
Rarely everything is ever 100%. That said, I would say it's mostly regeneration, primarily because the skin is oily, and the fact that his mustache is red. That's tissue function.
Okay, so what do you guys? Yeah, don't we do this now, or I was taught in my lab meeting we do this now. I say I'm still teachable. I tell my wife I'm still teachable, just a little thick in the head. So Joseph said, he started out very well done. Rarely is anything 100%, and I would agree. So as you move into your field, kind of a professional tip is don't try not to be absolute about most topics. It's kind of a good tip for life, actually. Okay, in like any circle. So in biology, words like always, never, usually are a clue on an exam that maybe that's not the right answer, right? Because there's variability. So he started out with that, and then he moved on from there and said, that being said, it's mostly regeneration or resolution in his opinion. And his answers were because of some oily presence on the skin, which means there's probably some sebaceous activity, and the hair grew back for the mustache. So I would agree with all of that. The other side of the equation, if you're trying to argue through the lens of repair and scarring or fibrosis, how would you set that up from this case study up here? There's a noticeable scar on the nose, on the bridge of the nose. Agreed.
It seems to be like somewhat raised. That's why
It does seem to be somewhat raised, especially at the level of the lips. You look at the right margin of the lips, there's a raised, potentially too much collagen, which might be indicative of a slight what? Keloid. Nicely done. Okay. Any other observations?
I'd say the lip is very telling for this repair because it's non-keratinized tissue, so you can really see the scar better in that area. And also along the mustache, I'd argue that there's less hair growth where that scar went through. So that's a big
Yeah. So to repeat, just for the video and those in the back, if you look at the lips, non-keratinized tissue, so the scarring is more prevalent. In addition to the keloid being raised, it has a different shade to it or color to it. And then in the space where the mustache grew back, the hair, may be thinner in that space, so maybe it's not complete resolution. I don't think anybody's wrong here. Some slight differences of opinion. You see how that works? Overall, I think the patient and the family are probably pretty happy. Okay, and then as experts, as practitioners, as we just played doctor here, and this was our case study, our ground rounds, I think we can kind of see where people sit. We know who the plastic surgeons are going to be, the ones that don't really love the outcome, right? We know who the orthopedists are going to be. Like, that's good enough, man. Man, I would have stapled that thing, as the orthopedist. But okay, nicely done. Nicely done. Okay, any other comments or questions? Yes. Not for this patient. There wasn't any post-year cosmetic surgery done. Great question. Where I thought you might be going with that, which I'll spin it in this direction and give you credit because you made me think of it, is if we waited a year longer, what would we see? Because this is a year mark. If we waited another year, what might we see? No surgery. Maybe a little bit more tissue remodeling. It's mostly done by 360 days. So it's probably not going to change much, and that's why I gave you the year photograph. You might see a little bit more. I would say post 1 year, doing a revision may not be as favorable as if you did it earlier. Just a clinical example, a case study, kind of weaving the science that we learned, the pathophysiology we went through, the technology, and then, sort of some clinical discussion where not everyone's going to agree in a room. I mean, that's inevitable. In this day and age, the more we can appreciate that, I think it's good for us to be able to be okay being with each other when we don't all agree, right? And that's going to be your future in medicine. You're going to have a lot of disagreements, I promise. Okay, we're going to shift gears again. So that was a company back in the 90s and the early 2000s. This is that one had a story to it where it was really expensive to make this technology. So the company created really awesome science, but the business side was lacking. I was really young, so I wasn't involved in the business. I was a bench scientist. And I mean, I was like 5 years old, so in the 90s. I'm kidding. So I know I should have worked harder. That's right. So this company actually went bankrupt and amounted to nothing. But we sold the technology, and the technology is still in the market today. It changed hands a few times. So you can look up Dermagraft, and it's owned by a company called Organogenesis. So if you ever, I hope this isn't you, if you ever run into a chainsaw, you could ask for Dermagraft by name. Axolotl was a company I actually helped start, and this was in the 2016. This company we ended up selling, and that went really well. Also really cool tech, but I learned a lot more, and I was older in my career, so I was part of the business side this time. Back to human tissues. Yeah, I like working with human tissues. So here, instead of discarded foreskins, we were using discarded placentas. So this is called birth tissue. So I set this up on Tuesday. Birth tissues can be, technically it could be an amniotic fluid. It could be the umbilical cord. It could be the blood out of the umbilical cord. It could be the placenta. The placenta is made up of two layers, the amnion or the chorion. Amnion is the baby side, the chorion is the mama side. So we were taking the placenta and we were focused on the amniotic side, which is the baby side, which is more neonatal, more embryonic-like. It's not embryonic tissue. This is after an elected C-section. So it's not a vaginal delivery. It's a C-section where we get these tissues. There's less contamination from delivery with a C-section. It's a surgical procedure. It's done sterilely. You still have to test for bacterial contamination, all that kind of stuff, but the tissues come out a little bit cleaner, if you will. So you see on the far right, this company was called Axolotl Biologics. The last company was called Advanced Tissue Sciences. We would decellularize the membrane, and we'd pull out the mesenchymal stem cells. We would grow them in an incubator in tissue culture flasks, and they would release these growth factors and cytokines. We would harvest the fluid, not the cells, leaving the cells behind, and we would create a regenerative fluid. There was a pro-healing fluid to inject into like a synovial joint that would lower inflammation, like a corticosteroid injection, but it wouldn't eliminate it. And I'll unpack that. It had a lot of other activities. It was pro-angiogenic. It was proliferative. it would stimulate every phase of the healing response, which is the key. It didn't just lower inflammation like a steroid injection. Then we took the graft that was decellularized. Sometimes we double layered it, and we would make a membrane for wound care to treat diabetic foot ulcers or non-healing wounds. Again, I've been in that world for a long time. So this is the graft. It doesn't have any cells on it, but we could actually seed it with fibroblasts. Now, these fibroblasts we got commercially. You can order them. We stopped harvesting. We were very early in the days. Now you can order a lot of these cells. You don't have to do the primary isolation. And back in my day, we had to walk uphill in the snow, both directions to the laboratory with foreskin and placentas over our shoulder. Now you just order them off your cell phone. I mean, anyways, you understand what I mean? Like now the field is advanced. So these were not foreskin harvested. We just bought these from a commercial source. But they're stained blue in this picture because what we're trying to illustrate is just 12 hours after seeding them with fibroblasts, which are skin cells, the fibroblasts lay down, because when they start up, they're like in a round ball, like in a fetal position. And the fact that they're all like different shapes and stretching out, that means they're really happy. They're grabbing onto their substrate. And so this was sort of an illustration to kind of demonstrate to clinicians. These were clinical slides showing how favorable axolotl dual membrane or a dual graft was for promoting fibroblast migration. Did I see a hand earlier? Okay.
I was just wondering if the stem cells are the same way.
The commercial stem cells, the one you buy, how are they harvested? Well, these ones are fibroblasts, not stem cells. Oh, how are these? Yeah, so they are, the commercial ones are from all different sources. So you can get neonatal dermal fibroblasts, which are usually from foreskin. You can get adult fibroblasts, which are usually from biopsies from patients that go see the dermatologist, and they're willing to send in a normal sample. You can get melanoma, cancerous cell lines. I mean, they're all donated cells that go to these companies, and they propagate them. They're all for informed patient consent. Like, we're not doing the Henrietta Lacks thing anymore. The Gila, if those of you that don't know who that is, so this is in the 50s. There was a woman named Henrietta Lacks who was diagnosed with cervical cancer. Well, unbeknownst to her, her cancer doc got a sample and shared it with some friends. The sample, like, this is really interesting. Well, they're cancer cells, so they just divide without ever dying. And they became affectionately referred to as HeLa cells, and they're the most studied cancer cell line on the planet. And she passed away, and she didn't authorize this, and her family has battled and battled and battled because they never got patient consent to do that. And so a lot of the documents that you fill out now and a lot of the rules about the way medicine is happening is because of people that have come before you, like Henrietta Lacks. So it's nice when we can tell their story to kind of educate the next generation of why are we where we are sometimes, right? Okay, the fluid. This is an ambient fluid. You can store it at room temperature because it's acellular, which is really, really nice. This is the first thing in the industry that was being used in the regenerative medicine space that was room temperature storage. So we kind of like disrupted the industry because everybody else was storing the stem cells in here, and they were making a live stem cell claim, and they were cryopreserving their vials. That means they were freezing them. So when you wanted to use them, you had to thaw them. But anybody that does cell culture knows that when you thaw cells out of the freezer, about half of them are dead. They don't survive the freezing process or the defrosting process. And you even go through the effort of getting rid of the water and soaking them in a cryoprotectant to try to get the water out of the cell so ice crystals don't form inside the cell. Right? Have you ever like frozen a water bottle in the freezer? What happens to your water bottle? Right? So if you like open the top and like, twist it and let it breathe, then it won't swell as much, right? But your water level will go way up. Well, in a cell, you'll rupture the cell. So you use a cryoprotectant, which is kind of like an antifreeze that you put in your car. It's the same concept. And even still, under those best conditions, you might get like 80% survival post thaw. So this was very different. And then we would irradiate it. So it was a sterile product. So you could inject it into joint spaces. We would load it in a syringe, preload it, and sell it as a axolotl shot. Same product as here, but it was just preloaded in a syringe so that practitioners could save a step. They're busy guys, busy gals. They don't need to be worried about that. So how did this work? So the video here is going to kind of walk through time-lapse photography on a stem cell that's dividing here on the screen, becoming 2 cells. And these growth factors that are being delivered into the damaged tissue would have activity on the resident stem cells to go into repair mode. And so what you're starting to see with them getting all bumpy, what do you think the cell's doing, getting all bumpy? What's it doing? It's manufacturing growth factors and cytokines into vesicles and spitting them out. And in the dish, every now and then you'll see something float by, right? I mean, this thing's getting really, really bumpy. But you'll see little things kind of float by here in a minute, as this goes on. Maybe I can play it one more time. So the idea is that we were teaching the field is maybe you don't need to deliver a cell therapy into a damaged tissue. You could deliver a membrane, or you could deliver a growth factor cytokine mixture that would act on the stem cells that are already in the patient's surrounding tissue that are healthy and cause them to go through a repair process. If it's in an older patient, you see all the stuff swinging by right here? So it's releasing stuff, and these floaties are floating through. It's creating a cocktail environment that promotes healing. So that was how we would explain that this product would work. So now let's get into some of the minutia. Some of the minutia of how did it work? Well, this slide should look somewhat familiar because this is highlighting the extracellular matrix at the top part. Here's the plasma membrane, and here's the inside of the cell with the cytoskeleton, the active filament. And here's our mesenchymal stem cells in culture, and they're releasing EGF, PDGF, and TGF-beta1. So epidermal growth factor, platelet-derived growth factor, and transforming growth factor. And color coordinated for your convenience. EGF stimulates cell growth and differentiation. Platelet-derived growth factor stimulates cellular proliferation. And then TGF-beta stimulates cell proliferation, the ECM to be made, the extracellular matrix to be produced, as well as promoting tissue remodeling. So do you see how all 3 of these things could positively impact wound healing? If we think about the phases of wound healing that we just studied. You with me? So then some bioassay tests that we would run. We were looking at the metabolism in fibroblasts in the presence of this regenerative fluid. So here you can see the metabolic activity. This is the control. Under normal conditions, these are skin cells being grown. And then you spike it with the fluid, the regenerative fluid, and you see a 2x increase in the metabolic activity. It's like they just had a Red Bull. And this is an animal study. This is a wound in a mouse model. And this is after 2 weeks. Control healing on the left. And this was a graft that was put, the graft material, and then an injection of the fluid. And you see a complete epidermis in 2 weeks, whereas this one is starting to form in the control. You see the difference? Very dramatic. So that was skin data. This is for chondrocytes. Now, human chondrocytes, there's a picture of human chondrocytes there on the lower left. What do chondrocytes manufacture? And where are they found? Chondrocytes. Cartilage and synovial joints. So as the wear and tear as we age, you get a lot of cartilage breakdown in the knees, the hips, the shoulders. And so we were looking similar type of assays, growing human chondrocytes in culture. We ordered these, right? Don't have to collect them anymore. And we're measuring the DNA content because that's a way to determine if you're stimulating cellular division and growing more chondrocytes that are making more cartilage, your DNA level will go up. So it's an indirect measurement of cartilage production. You're measuring the activity of the cell that makes the cartilage, the chondrocyte. So same kind of response. We saw a 20% increase after 72 hours. After 144 hours, we saw still a 20% increase in the amount of DNA after an injection. So it's having activity on the chondrocytes. These are synovial sites. Look a little more spindle-like, look a little bit more like neurons in cell culture. What do synoviocytes make? Synovial fluid. I saw somebody mouth it. Synovial fluid is like the lubricious oil fluid that permeates within a synovial joint. Has anybody ever felt synovial fluid? Like if you had synovial fluid and you rubbed it between your fingers, it would actually feel like motor oil. It's the weirdest thing. It's very clear and colorless, so it's not like an oil color, but it has that sort of slippery feel to it, just like motor oil. Similar type of data. We saw, about a 27.5% increase in the amount of DNA after 24 hours. After 96 hours, we saw almost a 60% increase in the DNA content of these synovial sites. So we're making more synovial fluid in a joint. We're increasing the production of cartilage by increasing the amount of chondrocytes that are present, or the activity of chondrocytes. Another assay looking at blood vessel formation. So we also know that in this fluid, we have fibroblast growth factor, angiopoietin-2, and vascular endothelial growth factor. I've already talked about VEGF, but all three of these are potent pro-angiogenic compounds. So they make more blood vessels. Very, very important. This is, the pictures of the three different stages of wound healing. What's funny, maybe not funny, haha, but what's interesting for you maybe to think about, these were slides that I took straight out of my lectures to physicians. This is how I would teach them how to use our product. And these three slides are the three phases of normal wound healing, the same stuff that we're learning about. So I was explaining to them what I just got done teaching you all is how this fluid impacts positively tissue remodeling by allowing for more blood vessels to form. We'll come back to the matrix metalloprotease in a second. So stimulating wound closure, you need to expand this capillary network. You need to perfuse the wounded tissue with more blood flow. And we do that by angiogenesis. So we have an angiogenesis assay where we would grow endothelial cells in cell culture. And with a program, you can identify different branch points. So you can identify if you've got a node. A node is where you've got a branch of one endothelial cell turning in, branching into a second endothelial cell. A mesh is where you get kind of like a ring, now you have a network of endothelium that are creating like a capillary network. So we call that a mesh. So you could actually quantify the network by nodes and meshes. So now you're getting a quantified numerical value. Are you making more angiogenesis? You follow that? And so if we quantify this, the negative control was actually just the culture media. That was the negative control. The positive control was spiking it with vascular endothelial growth factor. You can buy that too, and you can spike it with vascular endothelial growth factor. So if the bar was the same as the positive control, it's really not doing anything more than just VEGF. But what we saw is we saw even an increase with the fluid above the positive control, which tells us it's not just one compound that's having this effect, it's the synergistic activity or the collection of multiple growth factors working in concert, which is what happens in your body. That's the beauty of the released factors and also the beauty of the extracellular matrix proteins. Same thing with the meshes. So a more aggressive increase or a more interesting increase of a 4.5-fold increase over the control condition. So let's talk about remodeling. The last sort of activity on the tissue is looking at how it remodels of the extracellular matrix. So we found these tissue inhibitors of metalloproteinases, 1, 2, 3, and 4. And these were found in the fluid as well. And what these do is they're kind of like the brake pedal. So anytime you're remodeling tissue, you actually want to grow tissue and then you want to break down tissue. Grow tissue and break it down, right? Because you're breaking down the stuff that needs to be remodeled, but you need to lay down new tissue. So there is sort of the gas and the brake pedal. The tissue inhibitors of metalloproteases actually break down the extracellular matrix. And the TIMPs, or the inhibitors of that, prevents the breakdown. So it's important to have the brake pedal so you don't break down too much. Are you with me? Like the MMP9 that I showed on the previous slide, that is a matrix metalloprotease, which will break down the matrix and allow for remodeling. But you don't want to go too much. An example of this is out of the literature. This is a knockout mouse that is absent of TIMP1. So it's missing the gene that codes for tissue inhibitor metalloproteinase 1, the main one. And this is the wild type mouse on the left. And this is under a normal condition. This is so the left atrium and the left ventricle. And after an infarction, if you infarct that mouse, that's a normal mouse, you get a little bit of ventricular dilation. Do you see the difference in the black open space to the black open space? So you would expect after infarction that the ventricle is going to dilate. In our knockout mouse, this is not our work, but this is the literature. This is just trying to explain what TIMPs do. Here is the normal condition. You can already tell that there's a little bit of dilation more than the control. And then when you infarct it, the infarct is even more aggressive and larger because you're breaking down more and more tissue from the infarct. So just an illustration of why you need the brake pedal or why you have to have the inhibitor. And these regenerative fluids have the inhibitors as well. The last components that we'll look at are looking at basically immune function. So the other nice aspect about these regenerative fluids is they contain a MPO, a myeloperoxidase, and here is a neutrophil with this sort of budding ectosome, and that's what's blown up here. And this is releasing this MPO. And MPO is a molecule that helps the opsonization or the signaling to phagocytose bacteria. It codes it. So the neutrophil releases the myeloperoxidase. It binds, it's this molecule right here, so it's this one right here. It binds in concert with the bacterium. Interestingly enough, what allows the facilitation of it binding is what molecule? What is C3b? Complement. So here's a play back to inflammation where you're releasing myeloperoxidase in the presence of complement. It signals this bacteria to be phagocytosed and get rid of it. And so the fluids have a presence of MPO that acts as an antimicrobial. The last thing that they have, and then we'll get into some clinical results in the last couple of minutes, which I think will kind of drive home how it works, because this is very mechanistic, I understand. But the last piece, these growth factors, that are present within the fluid are also anti-inflammatory. Now, not a COX-1, COX-2 inhibitor, not a steroid, right? They're of the interleukin family. So you can see interleukin 10 and then interleukin 1 RA. That's the one receptor antagonist. And so again, what you're seeing is kind of the balancing act. You can see IL-10 stimulates B cells to differentiate and produce antibodies. And the receptor agonist, the receptor antagonist helps to brake pedal that response so you don't overdo it. So you're blocking a pathway of inflammation to lower inflammation, but not completely eliminate it. And you're like, wow, that's a lot of stuff. How did you figure that all out? We didn't figure out anything. We just took the mesenchymal stem cell and let it do its thing. Isn't that kind of cool? You let the biology kind of dictate what it needs to make, and then it does all the healing. So as we get into some of the clinical results in the last minutes here, this was a patient that broke her ankle, 47-year-old. She had 2 surgeries to try to address this broken ankle. And there were 2 other commercial products that were being used to try to help promote the healing. But it's been in this state, by the time we saw it in August of 18, it had been in this state for about 9 months. The bone was palpable through that wound. You could feel the bone. We treated. We had to do a releasing flap. So it got worse. It looked worse before it got better because it's swollen now. That's why we had this releasing flap, because we knew that it would swell. As it progressed, October 18th, so now we're October of 18, so we're like 2 months out. At the end of October, like right before Halloween, starting to see wound closure taking place. January of 19, September of 19, so about a year later, fully closed. This patient had tremendous number of comorbidities. Diabetic patient, had fallen out of their wheelchair because they couldn't walk anymore, tried to stand up and broke their ankle. That's how this happened. Okay, so this was a treatment with packing the membrane in the wound bed and then injections of the regenerative fluid. Orthopedic applications. This was a 39-year-old male who stepped in a gopher hole at like a football game and fractured their fibula. This is their right fibula fractured. This is 30 days later after just an injection with the fluid in a boot. 30 days is like 4 weeks. Fully healed fracture in 4 weeks. So skin wound healing on the left. This should be, I think, almost like second nature. This graph here superimposed over the different cartoon diagrams that we looked at today. This is the graph from Tuesday of the different phases of inflammation, proliferation, remodeling. And then here's the pictures that we started the lecture today in their respective categories. Again, normal process, right? Well, if you look at and compare and contrast bone healing on the right, and here are the references. You got time and days. You've got phase 1, inflammation. Phase 2, repair. Phase 3, remodeling. It's almost exactly the same. Isn't it kind of cool? So a lot of tissues in the body, not just skin and bone, but a lot of tissues in the body require some of the same inputs to be able to promote healing. And when we have stalled healing or chronic inflammation, it impacts the healing in all these tissues. So the last part of the story, currently as of January 17th. So this is an old slide, but kind of at our height, before we sold the company, we had 5 products on the market, and these are all the different places they were being used. We had wounds actually shrunk to 3% because once we discovered these kinds of results, it was like, wow. And the orthopedists just loved it. And so we had ankle, spine, shoulder, knee injections, soft tissue, foot, and wound became just a sliver of the pie, which was kind of sad for me, but that's okay. We're helping people, right? Emotionally, I kind of wanted to see more wound treatment, but I got my knees injected with this product. It worked great. But we sold the company, so I can't get the product anymore. So now we'll start another company and get new product. We actually went to the FDA for a biologic license application on our ambient product. We were in a phase 2 clinical trial. I'd enrolled about like 12 patients, and then that's when we exited. And that's kind of how that works. So you build technology, it starts working, you get so far, and then somebody comes and says, what would it take to make you not come to work tomorrow? Make sense? Questions? Okay, so what we've covered this week: tissue injury, tissue repair, fibrosis, and healing. We sort of compare and contrasted wound resolution, regeneration with wound repair or healing. We looked at acute inflammation versus chronic inflammation. I hope I've convinced you that inflammation is not a bad thing, but sometimes it's important to be able to try to modulate it to some level. But when we overdo it and we get rid of it completely, we literally just eliminate a line of defense for ourselves. Now transitioning to line of defenses, next week, we're going to queue up our third line of defense. Adaptive, specific, same, 2 words for the same thing, the adaptive or the specific immune system. It can sound a little complicated because it is. We're going to try to make it as straightforward as possible. We're going to highlight 2 characters, 2 main people, 2 main entities, the B cell and the T cell. And I would say this week, the macrophage, the neutrophil, and the fibroblast dominated, right? Next week, it's going to be the B cell and the T cell. And then the week after that, we have our exam. If you look at the exam week, we take our exam on Tuesday, and what do we do on Thursday? Whatever the heck we want, right? Go ride a bike, okay? Go take a nap. All right. See you all on Tuesday. Have a nice weekend.